Welcome to the American Academy of Actuaries webinar, Medicare's Financial Outlook and the Effects of Growing Enrollment in Medicare Advantage. Thank you for joining us today. I'm Corey Uccello, the Academy Senior Health Fellow, and I'll be moderating today's session. On May 6th, the Medicare Boards of Trustees released their annual report. This report assesses the financial status of the program, including separate analyses of Medicare's hospital insurance and supplementary medical insurance trust funds. Medicare Advantage plans, the private plans in Medicare, receive their funding from both the HI and SMI trust funds. MA enrollment has increased dramatically over the last decade, and now just over half of all Medicare beneficiaries are enrolled in MA. In today's webinar, our expert panelists will provide an overview of the 2024 Trustees Report and offer insights on how the increase in MA enrollment is affecting Medicare's financial condition. Before we get started, I need to go over some housekeeping items. First, I'd like to point out a few tools on your screen that can maximize your viewing and engagement experience. The individual windows are resizable and movable, so please feel free to move them around to get the most out of your desktop space. You may expand the slide area and the media player by clicking on the arrows in the top right corner of those windows. If you have questions for our presenters, please enter them at any time in the Ask a Question box. The slides from today's webinar are available in the Slides and Resources section. For answers to some common technical issues, please click the Help button at the bottom of your screen. We invite you to share your feedback on today's webinar by clicking the Take Survey tool on your screen. Webinars like today's are part of the Academy's service mission to the public and the U.S. actuarial profession. The Academy informs the public of the role and value of actuarial work, delivers value to members, assists policymakers in the formation of sound public policy, and sets professional standards for U.S. actuaries. The presenters' statements and opinions are their own, and don't necessarily represent the official statements or opinions of the ABCD, ASB, any boards or committees of the American Academy of Actuaries, or any other actuarial organization. With that, I'm pleased to introduce our presenters. First up, Paul Splatonik. Paul is the Chief Actuary at the Centers for Medicare and Medicaid Services and directs the Office of the Actuary. Next will be Michael Chernew, the Chair of the Medicare Payment Advisory Commission, MedPAC. Paul will provide an overview of the findings in the 2024 Medicare Trustees Report. Mike will then provide insights on how the increase in MA enrollment will affect Medicare's financial condition. In particular, he'll give an overview of how MedPAC has assessed the effects of MA coding intensity and favorable selection. Before handing it over to Paul, I again want to encourage you to submit questions throughout the presentation. We'll be leaving a lot of time after the formal presentations for Q&A. And now I'll hand it over to Paul.
Thank you, Corey. Good afternoon, everybody. Thank you for joining us for today's webinar. I'm going to talk a little bit about the financial status of the Medicare Trust funds as summarized, as disclosed in the 2024 Trustees Report. As Corey noted, this was released earlier this month. Some of the projections, some of the highlights, and in the interest of kind of leading into Mike's presentation, we'll talk a little bit about some of the MA experience underlying some of those projections. So basically, I'll be talking a little bit about the Medicare program, some of the background information, some of the very high-level results of the report, and some of the recent changes in the HI depletion dates, which have changed quite substantially over the last several years, and some of the Medicare Advantages. So I'd like to start with just an overview of Medicare. People generally have a good idea of what the program is and what it provides for, but the actual financing and the layout of how the benefits are provided and financed are actually somewhat unique. There are two trust funds, the Hospital Insurance Trust Fund and the Supplementary Medical Insurance Trust Fund. And within the SM, there are two accounts, the Part B account and the Part D account. All three of these aspects of these trust funds are distinct. The financing for each of these programs are unique, and amounts that are included in one trust fund can only be used to provide benefits for what that trust fund is authorized. And there's no ability for the trust funds to borrow or lend beyond what is in their trust funds. So starting with the Part A trust fund, this is the trust fund that provides for institutional care, so things like inpatient hospital care, skilled nursing, and hospice care. This trust fund is financed predominantly through tax on covered earnings, so taxable payroll. About 1.45% is payable by both employers and employees, where self-employed are responsible for both aspects of that for the 2.9%. And in addition, there is an additional 0.9% for high income earners. And I will note that 2.9% does not have a limit in terms of covered earnings, unlike the OASDI program, which does have a limit on the taxable wage base. Also, what gets into the HI Trust Fund is some revenue from the taxation of some of the OASDI Social Security benefits. And so typically when we talk about the trust fund status of the HI program, this is the one that has a depletion date. It's comparable to the discussion of the trust funds of the Social Security or OASDI program. And this is what typically gets the most attention when the trustees reports are released. But there's also a separate trust fund, the SMI trust fund. The Part B account within the SMI provides other medical services, so those that aren't provided in institutional care, so things like physician services, outpatient hospital services, things like diagnostic tests, medical equipment, ambulance, and physician-administered drugs. Separately, there's the Part D program, which provides prescription drugs. It's both Part B and Part D are voluntary, and so you can see that the enrollment in these two programs is somewhat less than what is enrolled in Part A, where there's more of an automatic enrollment. The general financing of the Part B and D programs are similar in that they are established annually and are predominantly funded by beneficiary premiums. So the members that are actually receiving benefits are paying a premium for those benefits. And the largest other component is the government contributions. There are some other pieces that get into the Part D side, but generally there's this large federal contribution and beneficiary premiums. The last piece on this slide is that the expenditures for the program in 2023, you can see here $400 billion in Part A, $500 billion in Part B, over $100 billion in Part D, and adding up all those things. And promise there won't be a lot of math. I am an actuary, so apologies. But you can see we are now, Medicare is now a $1 trillion program. There's not many of those. I could think of two others that come to mind. That's the Defense Department and actually, I'm sure about Defense. OASDI is clearly one that comes to mind there. Before I talk about the projections, I always like to have some context in terms of how this program how the Medicare program has evolved over time. And you can see that when what's included in the Medicare Trustees Report is a 75-year projection. This just looks back over the last 40 years. And you can see that the program has truly evolved quite substantially. Back in 1983, Medicare program was predominantly an inpatient service, provided for inpatient services. services were spent on inpatient services, and you can see some of the other pieces. And you jump to what this distribution looks like in 2023. It's vastly different. You can see that managed care is now the largest component by a long stretch, by a fairly wide margin. Inpatient, even in the interim, you can see in 2003 was starting to services, physician, getting more significant. But I like to kind of highlight on the program is going to evolve over time. The majority of these changes were in response to legislative changes. And so we don't know exactly how the program will change over time. But what is forecast in the trustees report is a projection of spending and use on. So just wanted to kind of have that as some grounding. So now, I guess the most attention in the trustees report release is that depletion date of the HI trust fund. And in this year's report, it was that depletion date is 2036, which is 5 years later than what was in last year's report, which is a pretty substantial change. You can see that there are two main reasons why the depletion date was pushed out. Basically, expenditures were lower and income is higher. Expenditures are lower, looking at the next 10 years or so, by almost 5%. The largest of these pieces is that there was a policy change on the MA program that changed the way benchmarks were calculated there. And so I'll talk about MA throughout the presentation. We'll get back to more on that. But over the course of time, there are ebbs and flows, not just in the program itself, but also various policies that affect Medicare Advantage payments. Mentioned, then the benefit changes is the change in the 2024 report is higher than what was included in last year's report by 3.2%. And basically, this is a result of the higher payroll taxes, basically more economic output, more economic growth, more people working, higher wages, contributing to greater taxable payroll, more income coming into the HI trust fund. And we'll come back and talk a little bit more about that as well. One thing I did want to mention as to some of these changes that have that were incorporated in the 24 report, that we have finally moved to the point where we're not in the middle of a public health emergency. And commensurate with that, some of the Medicare fee-for-service trends, the Medicare trends in general, they have stabilized. And so there's less reaction in the economy to dealing with the direct 19 pandemic. As a result, the trustees this year are placing a greater reliance on the more recent experience. And some of that experience is somewhat different than what was expected, prior to the onset of the pandemic. There's still a number of adjustments that are being made to the projections. The three that are listed here are the main ones. The first being morbidity improvements. So obviously, with the COVID-19, a number of additional excess deaths, in particular for the Medicare population. And so what that has left is that those that have survived, those that tend to be lower health utilizers. And so that is incorporated into the projections for the next several years. Similarly, there were some policies that just ended with the expiration of the public health emergency, and the policy around requiring 3-day inpatient stay in order to receive skilled nursing facility services. that one we expect to continue to play out over a number of years. The one where the spending is significantly below what was expected prior to the public health emergency is with respect to home health spending. And here we think at least this is partly due to some of the nursing or healthcare staffing shortages available. And so that we think it is going to impact trends over the next several years as some of those some of those shortages mitigate over time. So here's a picture of what the trust fund looks like. This is a comparison of assets in the trust funds compared to spending, the next year's spending. You can see over time, this tends to fluctuate somewhat. 2008 thereafter, you can see the significant decrease in that, largely coinciding with the retirement of the baby boom population. You can also see that on the 2020 time period was largely pandemic related. And you can also see that it compared this year's report compared to last year's report, that trajectory is pushed out somewhat significantly. There's a little more on this chart. Here we compare the current law income rates to the cost rates. So the black lines are the income rates. Dotted is last year's report, solid is this year's report. This is a comparison to taxable payroll. So the cost rates, the income rates, the income rates are not very sensitive. That's 2.9%. And it's a question of how much additional benefits you're getting from the high income earners and the tax on benefits. And so that's why there's generally not a lot of fluctuation in that current law income rate. You can see that the current law cost rates for the 2024 report, the solid line, is pretty significantly lower than where it was last year. That's in part due to that MA policy that reduced MA spending, but it's also related to the changes in taxable payroll, that there is more taxable payroll projected in this year's report, and therefore that being that the taxable payroll is effectively the denominator, that pushes the current law. You'll note that I talk about current law here. The trustees reports include information. The reports discuss that certain aspects of current law may not be able to be fully adhered to in all years into the future. On the HI side, the one that's most significant are productivity reductions to the payment updates. And so what the trustees do is they reference an illustrative alternative scenario where a different rate of reductions are reflected. Basically, the current law rates have economy-wide productivity, which the trustee, that would be challenging for healthcare providers that we think that have historically only annually in productivity improvements to continue to keep up with. And so what the trustees do is they reference this illustrative alternative scenario that the Office of the Actuary at CMS, we post on our website. And this is what that alternative, that cost rate would look like under the alternative scenario. And you can see that there is a pretty significant effect, that relatively small difference between a 0.4% annual update versus a 1% annual update, actually a reduction to the updates, can have a pretty significant effect, in particular over the long run. And obviously, the trustees' projections are, in large respect, focused on the long run. Another way to look at the results of the report is to look at this actuarial balance. This is the present value of income rates versus cost rates. You can see that in last year's report, this actuarial deficit was 0.62%. With the reduction in expenditures and increase in income in the 2024 report, that deficit is down to only 0.35%. One way to think about this concept is that 2.9%, if it was fully increased by the amount of this deficit, so if the 2.9% were increased by the 0.35%, up to 3.25%, then there would be no long-run actuarial deficit in the HI trust fund. Looking at Part B, try to again look at it in a big picture. There's not much of a difference here between this year's report, last year's report. I'll actually mention the odd shape where it's actually lower in the near term and higher than last year's report in the long run. I'll get to that in a second, but just wanted to talk a little bit about the general trends that we see here. There have been steady increases over the last several decades. You could see even as the rates of increase have slowed, we've had new enrollees coming into the program, and so that's why we have a pretty steady increase. 90 to the 2020 time period. We do expect that there is going to be in ages, there's going to be some increases there, and so this is looking at Part B spending. It's increased from about 1% in 2000 up to almost 2% here in the 2020s, and we do expect it to top out a little over 3% again under current law. I will note that, okay, if you're asking why does the pattern change compared to last year's report, and this is largely a change in the projection of GDP as compared to the changes in projections of the actual Part B spending. There's more income coming into the trust funds. Well, that also just means that's an extension of a greater GDP output. So that's one reason why the spending term. It's higher in the long run also because of those. One of the changes that was made in the 2024 report was a change in the fertility rate. And so this is the number of births projected per woman was reduced from 2.0 in last year's report down to 1.9 in the 2024 report. As a result, there's just a projection of a smaller population, many years out into the future, and therefore just less GDP output, again, way out into the future. Similar to what I mentioned on the HI side, there are a number of provisions in current law in Part B that might be challenging to adhere to. There's the productivity offsets that are applicable for many of the Part B services, but also with respect to physician updates, physician payments, those updates are generally limited to either 0.25% or 0.75%. For most, there's just, and those rates are just lower, potentially much lower than projections of inflation. And so similar to what's done with the HI spending, there's an illustrative alternative that includes physician updates that are more in line with what we think physician cost that's presented here in that illustrative alternative here. And again, you can see a very similar pattern that those updates, while each and every year, do accumulate to be a pretty significant amount. I think pulling all those pieces together, you could see that, as a share of GDP, current law is in the 2023-24 is just under 4%. It's projected to increase to over 6% under current law and over 8% under the illustrative alternative. Here's just a picture of how the financing of the programs have changed over time and into projections. You can see that on the left-hand side of this graph, financing was predominantly based on payroll taxes, with a relatively smaller piece for the premiums and the general revenue transfers. You could see as both the adoption of the new Part D benefit and program, those programs have increased. And those are going to be what's projected to increase even more over time. You can see that that actuarial deficit on the HI side, that deficit is at the top here. Those are the current law benefits that are not currently financed. So those are additional spending beyond what is received in income for those particular years. We've got trust fund assets to handle that deficit through 2036. Current law benefits would actually account for those deficits. I'm going to talk just about a couple of additional pieces before I turn it over to Mike. For several years, the trustees' reports had a pretty consistent HI depletion date of 2026. You can see from 2018 to 2021, the projection was 2026, which sitting here in 2024 would actually be pretty alarming. But over the last several years, there's been a number of changes. And you can see we're all the way up to 2036. And so wanted to just do a not quite deep dive, but a shallow dive, I guess, into what was causing that that pretty significant improvement in the HI depletion date. Starting with on the expenditure side, you can see that the dashed line is what was projected in the 2020 trustees report, which was effectively our last pre-COVID affected, pre-pandemic affected projection period. And the black line is what was projected in the 2024 report. You can see that, for those first couple of years of around 2020, 2021, but then we're consistently lower for the next decade or so. A number of reasons, just some of the spending is lower than what was for home health and some other services. But you could also see what I mentioned earlier with respect to the MA policy change, and that was a policy change that started to have an effect in 2024. It's actually phased in over, it's projected to be phased in over 3 years. You can see that that affects the trends over those next several years. And then at later aspects of the projection, these lines somewhat converge, and that's in part due to the higher rates of updates included in 2024 projection than in the 2020 projections. But all told, the amount of spending, you just add up all this spending, and in the 2024 report, spending is down by $323 billion, which does sound like a lot, but in terms of percentage terms, it's 3.23%. So that's a not inconsequential improvement in terms of the spending side. But here, if we look at what the change in projections on the income side, you can see again, there's very little effect, at the onset of the pandemic, but then the projection for the next several years, we jump up to a higher place than where we were expecting prior to the pandemic. And then so on the income side, almost 977 billion, 11.58% increase trust fund. And so just putting that next to 3.27 or so percent, 3.23% on the expenditure side, you can see that the biggest change in the story on the HI depletion date is really predominantly an income story. And now I just wanted to talk as a lead into some of the work that some of the information that Mike's going to talk about. And this might overlap a little bit, but here you can see how the MA program, Medicare Advantage program, has affected enrollment spending for the various trust funds over the years. You can see that the blue line is the enrollment. This is comparing total enrollment. There are some Part A only beneficiaries, and so usually when you look at A only beneficiaries as compared to those that can enroll in MA, Part A and Part B coverage. And so that the 2023 enrollment is actually a little north of 50%. But you can see from 2006 to 2023, dramatic increases in both on the enrollment and the spending. And you could see these amounts generally track pretty similarly. There's times where there's a little bit slower growth in one versus the other. But these increases have been pretty striking over a number of years. And going just one step down deeper, we look at bids and rebates. And now I might be getting into a little bit of the weeds for some of the audience, but the way that the MA made to MA organizations is that they submitted those bids are compared to a benchmark. To the extent that the benchmark, a portion of that gets paid to that organization in the form of a rebate. And those plans, either Part D benefits, additional A or B benefits, basically these rebates fund supplemental benefits. They provide additional benefits above the standard fee-for-service program, Medicare services to their organization, to their beneficiaries, to their enrollees. And so what you can see here, what I've compared here, this comes straight out of the trustees report. Over a number of years, you can see that blue line, what the bid variation, very dramatic. Really aligned to what might, what healthcare spending cost growth might be, maybe a little bit more, a little bit less in certain years. But you can see this variation in rebate levels is actually pretty striking. And so what happens is that there is generally, some upward pressure on rebates, and Mike will get into some of the reasons for why that might be. But often there is a policy or legislative or some other change that might actually put some downward pressure there. You can see in 2010, for example, that was the first year that risk scores were affected by a coding intensity adjustment. Don't want to get into all the details here, but basically pointing out that some of these ebbs and flows in terms of bids relative to rebates relative to what the bids are related to some of the various policies that have come out around the Medicare Advantage program. You can think of, well, why would MA plan costs, their bids, fluctuate or increase at a different rate than what their benchmarks might increase. And you can think of a number of reasons why this might be, and Mike's going to get into a couple of them specifically, but I'll just go through a list. It's like, well, one, MA plans can offer, a limited network, for example, or have preferred provider payment arrangements, or can put some controls in terms of utilization management where that doesn't exist in the fee-for-service program. Might have other programs that are designed to keep their populations healthier. There's a number of policy, things that MA organizations can do that try to control their costs relative, that aren't present in the fee-for-service. But there's a couple of other things that they can do as well to kind of increase their, or to increase that gap between their costs and the benchmarks, and that is that they can code more, greater selection, that's talk about. But basically, to the extent MA plans get paid based on the diagnoses that they submit for their enrollees. So to the extent that more diagnoses for their enrollees are provided, they get paid more. And so obviously those incentives are different than what the incentives are in the fee-for-service program. And MA plans have done a number of things that are trying to address that are designed to increase their revenue by identifying more diagnoses. And so I'll look forward to kind of hearing Mike's talk on that. I'm going to turn it over to Corey to transition us, and she might have a question for me, but I think that was the last.
Yes.
Turn it over to you.
Yes. Okay, thanks a lot, Paul. That was really great. I do have one clarification question that came in regarding that 4.7% reduction that you said was mainly tied to the MA policy related to the education expenses. And the reaction was, wow, that seems like a really high number for this one thing. Is that really most of the 4.7%? Is there other stuff going on underneath that? Can you just expand on that a little bit?
Sure, I'd be happy to. Yes, it is big. A number of things that I'll talk about there. One is that that 4.7%, that was the effect over a 10-year projection window. The actual policy is being phased in over a number of years, and so that wasn't all built into 2024 rates, for example. So that's one piece of it. The other piece is that, again, not wanting to get into the nitty-gritty detail, the fact that what we're talking about is medical education, for the way medical education is treated for the development of these benchmarks. Medical education is just paid to these hospitals, and hospitals is purely coming out of the HI Trust Fund, and so are hitting against the HI Trust Fund. They're the Part B, the SMI Trust Fund doesn't get any of the regulation, is not changing at all, and so it is actually somewhat leveraged. The overall change in the MA payment is actually much less than the 4.7%, and it's phased in, and it's just leveraged up because it's just affecting the HI program.
Okay, I think that makes a lot of sense. Thank you. Okay, now we will turn things over to Mike. Go ahead.
Corey, thank you so much. And Paul, that was both great work and terrifically important. So thank you for that. And thank you for leading into the topic I'm about to talk about, which is Medicare Advantage. And I'm thrilled to be here to speak with everyone in the audience about the Medicare Advantage work that MedPAC is doing. And I'm going to focus on the comparison of spending between Medicare Advantage and fee-for-service Medicare. At the onset, I'd like to say, right now, this is really just a mathematical discussion of what we think the payment in Medicare Advantage is relative to fee-for-service. I'm happy to have broader discussions about what policy implications to draw from that, but mostly I'm going to focus on just the comparison. So I'm going to give a brief overview of MedPAC, who we are, what we do, why we're great. And then I will have a discussion, as I said, about our analysis comparing Medicare Advantage and fee-for-service spending. I'll focus on the payments and MA plans, and then estimates of coding intensity and favorable selection, which I think are getting a lot of attention. And then I really, really look forward to questions in the discussion. So brief MedPAC overview. We're an independent, nonpartisan policy commission. We provide technical advice to Congress on issues affecting the Medicare program. There's 17 commissioners who are selected by the Comptroller General at the GAO. We're chosen for our experience and subject matter expertise. There's providers, payers, researchers, beneficiary-focused individuals who are commissioners. I should emphasize that although they come from various backgrounds, we ask everybody to check their interests at the door and don't consider any of the MedPAC commissioners representing any particular group per se, although obviously some have more expertise in some industries or some perspectives than others. We get 3-year terms. We can be reappointed once. So that's how it is set up. The commissioners are supported by an outstanding staff of 25 to 30 analysts. If you know any of them, you'll understand they are really experts in their various fields and unbelievable experts in all the nitty gritty of the Medicare program, which in case you're not aware is very nitty and very gritty. We have seven public meetings during the year. They are available to watch just as this webinar is. The staff present analyses, there's site visits, there's data analyses, and then the commissioners engage with that work and the agendas published in advance. And we welcome any of you to join any of the MedPAC meetings. There's a lot of ways that we're transparent in our work. I won't go through all of them. I mentioned a moment ago that our public meetings are broadcast, the transcript's available. But really, a lot of what happens is we engage in a number of ways with people in the public that have questions or reach out to us. At the end of every public meeting, I ask people for their comments on the material, and people send them in. The staff takes it unbelievably seriously, actually, all the various stuff that we do. And there's an analytic agenda published for the upcoming year for all the other various things we do. So again, please reach out if you have particular questions about our work and what's going on. Now to the meat of the matter. As was noted, I'm going to talk about Medicare Advantage and fee-for-service comparisons. And although the origins of the it's changed names, but the program that covers private plans and Medicare has changed over time. It was really designed to be relatively small compared to the traditional Medicare program in the way that it was set up. And in fact, it has grown, and now over half of eligible beneficiaries are enrolled in Medicare Advantage. So it is really a core component of what we think of as Medicare now is being managed by private plans, and the trajectory is likely to continue, suggesting that Medicare as a program, although we often talk about Part A, B, D, most beneficiaries are likely to be enrolled in private plans that are managing all of that for them. So how are Medicare Advantage plans paid? You know, any one of these slides I could probably talk about for 15 minutes. I promised Corey I wouldn't. So sort of quick overview. Payment is based on plan benchmarks, the plan quality, the plan bids, and then adjusted for risk scores. I will focus a lot on the risk score component. But the benchmarks range from 115% of fee-for-service in the lowest fee-for-service spending counties to 95% of fee-for-service in the highest spending counties. And those are a policy decision. So just as a general point, it's done in quartiles, but when half of the quartiles are paid more than fee-for-service, it's not surprising that that will tend to encourage payment for Medicare to be above fee-for-service, just mathematically. And then the quality bonus program pays plans more, 5 or 10%, for achieving 4 or more stars, and that's above the line, so that further increases how much Medicare Advantage plans are paid relative to fee-for-service. And again, that's a policy decision. Then the plans bid. They're supposed to bid what they expect to spend to cover A and B services, and of course, there's also MAPD plans. I'm going to put the PD part of that aside. but they bid relative to what they expect to spend. And that influences their payment. Medicare takes a portion of the gap back, and the remaining portion of that gap can be used to fund the rebate, which Paul spoke about a moment ago, and I'll say maybe a little bit more about it. And that's all sort of if you had a standard 1.0 risk person, but then the payments are adjusted up or down based on the risk score. So if the MA plan has people that are estimated to be less healthy based on the diseases they have, the plans are paid more relative to if they have people that are estimated to be less healthy. And as it's clear, almost all the plans bid below their benchmark, and because there's a gap, some of that money goes back to the government, and some of that money is kept by the plans as a rebate, and that rebate percentage depends on quality and is used to finance a lot of different benefits. So some of the benefits are just lower cost sharing, deductibles, cost sharing, things like that. Some of it goes to buy down premiums for Part D plans. If it's an MAPD plan, for example, some of them Part B plans, they can buy down the premium. In other situations, they're adding extra benefits, vision, dental, hearing, and some of the other benefits like meals, transportation, things like that. So that's sort of the basic payment approach and where the money goes. So a core issue that we're going to talk about that I'm going to emphasize here today is how risk adjustment works. So the risk scores are a beneficiary-specific index that gets aggregated to a plan of expected spending relative to the national average spending. So the national average is 1. It's based on beneficiary demographics and their diagnoses. I should say there's different, it's not just one model. There's models for people that are dual, for example. There's I think 6 or so different models, so that they're estimated in different groups, and each of the models will have diagnoses and characteristics in them. It's not only used to pay the plan, they use it to standardize the fee-for-service spending that forms the benchmark. So if the fee-for-service people are healthier than the average fee-for-service person, there's an adjustment there. Crucially, I should pause. Crucially, the risk adjustment model is developed using data from the fee-for-service population. So it affects spending of fee-for-service people with a set of demographics and diseases, and it reflects the diagnostic coding patterns in fee-for-service. So in case I was breaking up, I will emphasize again, the risk model is calibrated based on the diagnostic coding patterns of beneficiaries in the fee-for-service system. And that's important when one thinks through this. So when we compare spending, we want to account for differences in health status and geography, and MedPAC does adjust for things like geography in its models. And then we want to get relative spending in MA relative to fee-for-service, and that's going to vary for a bunch of reasons, all of which are taken into account in the MedPAC models. I'm not going to emphasize one of them, many of them. I'll focus on 2. But the benchmark, so I mentioned the 115% of fee-for-service, that's obviously going to matter. The quality scores, if you're performing highly, you get paid more above the line. Plan bidding behavior is important. The lower the plans bid, the more the government pulls back, and so the lower MA spending would be compared to fee-for-service. And then the things that I'm going to focus on mostly today is the intensity of Medicare Advantage coding relative to fee-for-service and the favorable selection of beneficiaries into the Medicare Advantage program. There's a range of other things you might want to know holistically about the Medicare program. Is it adding value, for example? What's its impact on providers, for example? There's a lot of broad questions about Medicare Advantage policy that are important. I'm going to talk today just about the spending comparisons and understand that the spending comparisons alone don't drive whatever policy decisions you may or may not think people on the Hill should make. So that's going to be my focus now. All right, move forward. There. So MedPAC's comparison of MA payments relative to what they would have been. This is the sort of the base number. We start with sort of the core number, MA payments compared to local fee-for-service spending adjusted to have the same risk profile. So that's kind of the base number that everything's built off of. And then we adjust that for unaccounted for differences in the risk scores. And there a function of two things: coding intensity. I'm going to talk a lot about coding intensity. And the second one is going to be favorable selection. But the summary of the number that was released in our recent report is that in general, before coding and selection, we're at about 100%. And so if you take all the other things I mentioned, they kind of net out to being about parity. The coding effect adds about 13% and the selection effect about 9%. So on balance, we think that plans are paid about 22% more than would have been spent on the same beneficiaries had they been in fee-for-service. I want to emphasize, very importantly, I did not use the phrase, I'll emphasize again, I did not use the phrase overpayment. There's some normative implications there. I simply said paid more than what would have been spent in fee-for-service. So I think the key question is to give a little bit more detail to unpack something about what we mean, how do we measure the coding effect, and what do we mean by, and how do we measure the selection effect. So here we go. I need a deep breath before jumping into this. Everybody take a sip of whatever they're drinking. So the incentives to code are different in fee-for-service than they are in Medicare Advantage. In particular, in the fee-for-service system, providers don't have an incentive to capture necessarily all the diagnoses that their patients may indeed have. Whereas, because they don't get paid more for the diagnoses. In Medicare Advantage, the plans do have an incentive to encourage providers or otherwise collect data on the medical conditions that their beneficiaries have. And they have quite an infrastructure to do that, and that includes certain tools that don't exist. For the most part, there's some aspect that they do, but they don't, broadly speaking, exist. And they're not widely used in fee-for-service, the health risk assessments and the chart reviews. And these greater use of these tools allows Medicare Advantage plans to capture more diagnoses. Just to be clear, I'm not claiming that the beneficiaries don't have those diagnoses, although in some sense they may not, but simply they're capturing diagnoses that otherwise would not have been captured. This is fundamentally a calibration exercise when we're doing the comparison. To estimate the coding intensity effect, we use two different models. I'll talk about them in the next slide in a moment, but they produced really remarkably similar results, less than 1.5 point between them. I'll show you a slide in a minute. And they're broadly consistent with a number of estimates published in the academic literature. So let's go to the next, I'm turning the slides. So this is a chart. The first method, which was, it's here in the solid line, was what MedPAC has traditionally done. It's called the cohort method. And essentially, there's been revisions of it over time, but it basically looks at individuals when they join MA and follows them over time to see how their codes evolve relative to codes evolving, say, in fee-for-service. And that's the cohort method. And the DECI method, which has been talked about in other academic literature, really makes some assumptions about relative health and then compares adjusted risk scores almost at a point in time. And you see stunningly similar comparisons. Because the DECI method, the demographic estimate of coding intensity, seems to give a very similar result and in some ways allows us to avoid certain assumptions about longitudinality, for example, of populations, and is easier to explain. We're focused now on the DECI method. But the key point here is I think our coding estimate is ballpark where a lot of other researchers are, and ballpark similar across the different methods we use. So that's the number we get. One of the nuances here that's very important is that CMS applies a coding and intensity factor, or a CIF. And so when we estimate our coding number, we get a higher number and then subtract out the CIF. So after accounting for that coding adjustment, the CIF, if you will, we project that 2024 Medicare Advantage risk scores are about 13% higher than they would have been in fee-for-service. And again, that's pretty consistent across the different analytic methods. That accounts for about $50 billion in higher payments to MA plans than otherwise. If all you did was say, what would these people spend in fee-for-service, holding fee-for-service spending and spending patterns and everything else constant, you get a sort of just mathematical number of 50 billion. The coding intensity, we believe, has grown over time. You saw that in some of the slides. and we project it forward using past trend data, and then we account for the V28 risk model. We can have discussions about how we account for the V28 risk model, but I will say, and this is sort of a broad comment of all of our work, we're going to learn more as more information about what's happening with V28 emerge, and we're continually refining these methods and the methods for selection as well. There's a lot of tricky assumptions that go into this. The good news, I'll tell you, and maybe not the good news, but the news, depending on your perspective, I'll tell you in a little bit, is that our estimates are ballpark similar and robust to a lot of different assumptions. One thing that doesn't get enough attention, and it's funny because we're trying to give more of this attention in the report, is the incredible heterogeneity across Medicare Advantage organizations. So I mentioned coding a moment ago, but if you look at the coding intensity across organizations, there is widespread variation in coding intensity across plans, with some plans really coding much higher than the coding intensity adjustment and others well below. And I think this heterogeneity across plans in how they're coding is important, not just because of sort of average spending, but how it affects the competitive dynamics of the Medicare Advantage market now and going forward. And I think some of the policy options that we consider not only address the overall average payment, but maybe even more importantly, address the heterogeneity in things like coding and selection across different plans. I mentioned chart reviews and health risk assessments. Our analysis suggests that, broadly speaking, about half of the coding and intensity is due to health risk assessments and chart reviews. The way that this analysis is done is essentially we identify individuals whose diseases would not have been picked up using the general codes, but they were picked up either on only health risk assessment, only chart reviews, or some combination of health risk assessments and chart reviews, but not on the claims. So you can see there the numbers, but the general point is that's about half of the coding intensity numbers. In 2022, it looks like it's roughly 9% of the total. The other is not. And these numbers are before the coding intensity factor adjustment. So these would go up to a little bit higher, and the coding intensity factor would bring it all down. But this is a big deal. How these codes are captured and the asymmetry in how they're captured between Medicare Advantage and fee-for-service. So another deep breath, and I'm going to jump into the newest type of analysis we've been doing, which is favorable selection. So let me start with a really basic point that I think folks on the webinar will understand. For any given risk score, there's a distribution of actual spending around that risk score. Some people spend more or less than they would be predicted to spend based on their risk. Favorable selection occurs when lower than expected spending individuals choose Medicare Advantage over fee-for-service, or people whose risk score would be 1, but in reality, if you had a full understanding of their expected spending, you would expect them to spend, say, 0.8 for a range of reasons, or some version of that. Importantly, so it's a residual. It's a residual between their expected spending and their actual spending. And importantly, that can occur at any level of risk or any level of severity. In fact, in some ways, people that are expected to spend a lot of money, there's almost more room for a favorable selection, because if you're expected to spend nothing, you can't really have much favorable selection. If you're expected to spending a lot, there's a lot of variation around that high number. And if you systematically get people in the lower end of spending, given that high predicted spending, you can actually have quite a lot of favorable selection in people whose predicted spending is actually quite high. And we've been publishing on this concept for a long time, since 2012, but really intensively in the past several cycles. And now we've added some numbers to this. So let me talk through a little bit about these numbers. They may be less familiar to you than some of the other coding numbers, which we published for a long time. I mentioned what favorable selection fundamentally is when individuals who are systematically going to spend less than their risk score would predict. I am not claiming this is due to intentional plan behavior. There may be things about the plans that attract people that would have lower than predicted expected spending. Maybe networks and prior auth, for example. So individuals, may select into MA because they're not as concerned about various prior authorization or network limitations. And higher cost sharing for most services compared with Medigap also could influence who's joining the MA plans. That may not be done because plans are trying to induce selection, but it may at the core affect selection. And that could be influenced again by beneficiaries' perceptions of those things, or more importantly, the people that join MA may be individuals who systematically have a preference for less spending overall. I had a grandmother that would go to the doctor every instant she could. I had a grandmother that would never go to the doctor. If my grandmom, who never wanted to go to the doctor, joined MA, that would be favorable selection, even though they actually looked stunningly similar in other dimensions. Beneficiaries that don't have generous supplemental coverage would spend less in fee-for-service. If they join MA and get more supplemental coverage, they would spend more, but their fee-for-service spending would have been systematically lower than predicted by the risk score. And so these are the type of things that are happening in terms of favorable selection. The same would be true if people are joining in areas, sort of micro markets, where they have less access to care. So how do we get our selection estimate? We start by analyzing the fee-for-service spending in the year, and I want to emphasize this, in the year prior to MA enrollment for beneficiaries that subsequently join MA. So imagine it's 2015, you have a bunch of people in fee-for-service, you look at their predicted spending based on the risk scores when they're in fee-for-service, then you separate them out based on who joined MA in 2016. So this is after the base estimate. So your analysis is 2015, the joining of MA is in 2016, and you look to see what their risk-adjusted spending was in 2015 before they joined MA, and the people that join MA subsequently have systematically below predicted spending when they were in fee-for-service. I want to emphasize when they were in fee-for-service. So nothing that the MA plans were doing can influence that baseline number. And that gives you your starting point. And then there's a bunch of analytic issues that you have to worry about. Selective attrition, people leaving that were leaving MA that were in differential health status, or regression to the mean. And these are things that we keep us up at night. We're continuing to work on them, but there's a bunch of match control approaches to trying to measure selective attrition and regression to the mean. We can, you can see how we've done it. But I think in general, the good news is that the results so far have been robust to a lot of things. So if you adjust for selective attrition, regression to the mean, you take the base case selection number, we estimate there's about a 9% higher payments for people that are in the people in MA would have spent less. They're getting paid 9% more than they would have spent in fee-for-service, because in fee-for-service those people would have spent below what was predicted to be spent in fee-for-service relative to what they're getting paid. Surely someone will ask me a question about that, because if I see the transcript, I will be embarrassed by how unsmooth that explanation was. But the gist is that the favorable selection estimate of about 9%, so MA is being paid 9% more than people would have spent in fee-for-service, because their fee-for-service spending would have been lower than the risk score would have predicted. And the coding estimate, they add up together, which is how we get to the estimate that we have. These estimates of selection much more complicated to get at, but they're broadly consistent with other research have found in the literature, 7 to 16%. So I think, maybe we're a little bit for the low end, depending on what you think, but and I'm sure there's new papers coming out constantly that have different estimates, but we're not wildly out of whack with, I think, what a lot of other analysts have been saying regarding selection. And because there's so many assumptions, we've done a lot of tire kicking, and it's really robust to a number of things we've done. Aspects of decedents are always a big deal. Selective attrition becomes a big deal. We're continuing to work there. And beneficiaries with less than 2 years of prior fee-for-service coverage is an issue. We're trying to deal with that. But I think the key takeaway is our estimate was 22%. We could probably tell a story why it's a little bit higher, a little bit lower, but ballpark that number, when you add the coding and selection together, you get a big number for the difference. So we've heard a lot about that. I can't see all the people listening, but I imagine we've heard a lot about that from some of you. So let me try and parse some of the comments that we've had. There's some question about whether or not we've dealt with the analytic issues correctly, regression to the mean and selective attrition. And actually, those are we actually haven't heard many of those critiques, to be honest with you. We take all of them seriously, and we continue to look at them, but the bulk of their critique has not been, there's something wrong with what we're doing. Or the number, your regression to the mean analysis should go this way or that way. You need to have a different matching algorithm or some version of that. We haven't heard a lot of those critiques. There's a lot of questions of people trying to understand how can these estimates be consistent with other known facts. The main one would be some version of the story. We know that sicker people are joining Medicare Advantage, dual beneficiaries, for example. How can you tell us there's favorable selection in Medicare Advantage when sicker people are joining Medicare Advantage? And the answer to that is selection is conditional on the risk score that is projected. So there is a model of risk for duals. When you get people with very high risk scores, duals, high expected spending coming into MA, there's actually more room for selection within that group because selection is not based on their predicted spending. It's based on the estimated actual spending relative to what is being predicted. And so there can be actually quite a large selection effect in a very sick group, and we're doing more work to understand that more, and hopefully stay tuned. And the last type of question we hear is some version of, yes, we understand all of this is going on, but don't you think that this gap is justified? And the main comment there involves some version of, this is not MA overcoding, it is fee-for-service undercoding. And as an aside, I have some other research on fee-for-service undercoding, and the report acknowledges there is some fee-for-service undercoding. We are not making a normative assessment of how much is fee-for-service undercoding versus MA coding sort of more aggressively versus sort of pure fraud. One could debate those components, but the broad point is, regardless of those components, there is a difference in predicted spending. So this is just about parity. It's not making a normative comment. And if fee-for-service is coding a lot less and MA is coding accurately, there is still a gap between MA and fee-for-service coding, and that's what we're measuring. You can debate how one wants to deal with that in the policy sphere, but as a pure mathematical measure of the gap, undercoding in fee-for-service is something that we do and we believe we should include in our measure of the MA fee-for-service spending differential. And I really, really, really hope that's clear so I can avoid about a dozen emails later. Anyway, if it's not clear, luckily we have some time for questions, and I would be happy to repeat my, hopefully with more clarity, my explanations. But again, Corey, thank you so much for the opportunity to speak to this audience.
Thank you, both of you. This has been just really a tidal wave of information. We do have a lot of questions. But keep them coming. If you have additional questions, please submit them now. I'm actually going to start with my own question that I stole from another webinar on the Medicare Trustees Report, because I think it's a good one. The 75-year HI deficit, as Paul said, is 0.35% of payroll taxes. I'm assuming that that's the lowest it's been for quite some time. Why don't we just raise payroll taxes by 0.35 percentage points and just kind of call it a day? Because that, as Paul noted, would achieve solvency for the next 75 years. I don't know which one of you wants to take that.
Paul wants to take that.
Thanks, Mike. So if the problem we were trying to solve was what can we do to satisfy the actuarial deficit, that would be a perfectly reasonable solution to consider. There's other possible ways to do it. You can try to reduce spending by a fraction of a percent. I forget exactly what it was in this year's report. I think it was either 6 or 8%, something like that. And so there are a number of ways to address the actuarial deficit. It might not surprise many on this webinar to hear that members of Congress probably aren't all that excited to consider increasing taxes in most forms, but in particular to solve a problem of H deficits, which, according to the trustees, will not present a problem benefits to anybody for roughly a number, for 10 or 12 years or so. And so it's trustees report makes clear that to address any of the potential issues that are identified in the trustees report with respect to either HI funding or the payments that are going to Part B or Part D program, to the extent that there are going to be changes to address those issues, the earlier the better, because there's more time that is afforded both taxpayers and beneficiaries and providers and all the various constituencies better. However, that doesn't necessarily align all the time with goal priorities might be at a particular moment.
Mike, do you have anything to add to that?
No, thanks for asking.
All right, so we have some questions about coding and risk adjustment, so I'll try to group some of these together. First of all, clarification on the bids and the 1.0 national average risk score. Is that the national average of all fee-for-service beneficiaries, national average of all beneficiaries? What is this 1.0 supposed to reflect?
I'm going to go with fee-for-service beneficiaries. So the fee-for-service beneficiaries in general would be considered a 1.0 risk score. It gets I'm not going to claim to know all of the nuances of what happens through subsequent adjustments, but I think conceptually the goal is to have the average fee-for-service beneficiary have a 1.0 risk score. There's a bunch of normalization factors that go in there.
Okay, can you explain? I know, Mike, you talked about this. I don't know if you did too, Paul, but can you explain why fee-for-service providers would have less incentive to code diagnoses compared to Medicare Advantage, especially if fee-for-service providers want to be paid more? Don't they need to code more?
Not for the diagnoses. So they can get paid for the procedures and the things that they do. But if someone had diabetes and they were at a visit for a strained ankle, coding diabetes isn't going to change what they got paid for treating the strained ankle in the way that fee-for-service works.
Is there any way, and maybe this is kind of almost a bit what you talked about in the favorable selection discussion, but what methods, are there methods, have there been methods used to compare actual patient risk for MA versus what was reported? So how does kind of their actual spending compare maybe with what you would expect from their risk score based on what was reported?
So I'm not sure this answer is going to answer that question. I'm going to do my best. If you look in the year before they join MA and look at the actual spending of MA beneficiaries, future MA beneficiaries. So these are fee-for-service people. There's future MA beneficiaries and there's people that stay in fee-for-service. If you look at the future MA beneficiaries, when they're in fee-for-service, the year before they join MA, their actual spending is give or take 10% below what their predicted spending would have been in fee-for-service. That becomes very difficult to project forward because, of course, the MA plans are doing things to try and manage spending, prior auth, network restrictions, a whole bunch of beneficiary engagement activities to try and hold spending down. All those Medicare Advantage activities would lower actual spending relative to something expected. None of that is captured in the selection estimate. The selection estimate is trying to run a thought experiment of a group of people that joined MA next year. What would their spending trajectory have been had they not joined MA? So there's no MA influence on spending in that activity. But I think the direct answer to your question is in the year before they join MA, future MA enrollees spend, roughly speaking, 10% less than projected when they're in the fee-for-service system and then coded as if they were in the fee-for-service system.
So how generalizable is that MA population who switches to MA from fee-for-service rather than joining MA from the get-go? I remember years ago there was analysis or looking at the share, like when do people join MA? And in that it was still more like 66, 67 than 65. Is that still the case now?
Yeah. So some of the sensitivity analysis tries to adjust for that particular issue. That is an important issue. I think as a general point, that's an important issue. And then there's a question about over time as they regress up to the mean or attrit, what happens to them. So there's a broad question about that generalizability. Most of the underlying analytic work that we're doing is trying to focus on those types of issues about how to deal with people that joined MA before you had, estimates, pre-estimates, and varying things like that. So I appreciate the question, Corey. I don't have a mathematical answer for you. I think that's the trick in how all of this plays out to get the analysis right, and I think it's a reasonable question. But again, the robustness stuff that we've done suggests that's really not what's driving a lot of what's going on here.
Okay, I have one more kind of coding question, and then I'm going to get Paul with some questions. So has the CMS ACO model incentivized providers to code more diagnoses? And has that changed the difference between fee-for-service and MA diagnosis coding?
So there are incentives in the ACO program, and I will emphasize for those that aren't aware, the ACO program is part of fee-for-service Medicare. So ACO programs code more, that would be a coding and fee-for-service. The risk adjustment system in the ACO programs are different. In other words, there's not this external comparison, there's some caps and a bunch of other things. I don't have a particular estimate of how much the ACO program affected coding or did not affect coding, but over time, the effect of coding has not diminished dramatically. In fact, we see a continued trend in greater coding. And again, I think some of that is because of the use of tools that may not exist as heavily in the fee-for-service program, chart reviews, et cetera, as opposed to necessarily just underlying coding of the providers. But in any case, I don't have a good answer to how much of this is the ACO program, but whatever incentives are embedded in that, and I do agree they exist, it hasn't really changed dramatically the coding estimates that we've seen.
Just to expand on that point there. So there is probably some degree of spillover between some of the provider behavior, physicians coding more for their MA beneficiaries. It's probably pretty likely that they're also seeing some fee-for-service beneficiaries, and they might code more for those individuals as well. I think distinctions, though, between coding in MA versus coding in fee-for-services that typically have these specific tools, home risk assessments, things like that are specifically designed to identify codes, and that just isn't replicated in the fee-for-service program.
Or the ACO portion of the fee-for-service program to the same degree.
Okay, this question goes back to Paul's presentation, and I think it's reflecting the improvement in the HI trust fund. And this person asks that, or supposes that the wage inflation and general inflation, including medical care costs, should be correlated to some extent. But you noted that really most of the action on the improvement was on the payroll tax income side. So is that right? What's kind of going on here that there isn't that correlation that this attendee would expect?
No, there's actually it's a very good question because we do expect, and you actually see that in some of those projection slides that I had up earlier, that there are, in particular, the spending rate increase in the 2024 projection as compared to the 2020 projection, that slope is higher in the 2024 than it was in the 2020, in part because the expected inflationary outlook is higher. But what has contributed to that improvement in the trust fund is that while we have experienced, well, actually, I'll say two things. While we have experienced this higher rate of inflation in the relatively short order here, we've also seen just decreases in utilization, or at least not, slower rates of increase than what was previously expected. So that's one piece of it. The second piece of it is that a lot of these payment systems are effectively lagged, that they're prospectively set, and most of those payment systems do not have a retrospective adjustment for for this type of payment error. So, for example, in setting a payment update for a particular service, we'll say inpatient, perhaps it was assumed that there was going to be a 2% rate of inflation. If it turns out that the actual rate of inflation was closer to 4%, that 2% gap is going to show up in this, as effectively savings, because in subsequent years, we're not going to increase those rates by that 2% because there's not that retrospective error adjustment for most services in the Medicare program.
So there's been a lot of work over the years on payment rates for Medicare versus payment rates in the commercial market. And just recently, RAND put out a study that reported that private insurers are paid about 2.5 times Medicare costs for inpatient care. The illustrative alternative assumes 1.7 times the amount. Are those the differences between the 2.5 and the 1.7? Are those reconcilable? Why do they differ? Should they differ?
So just specifically on the illustrative alternative, there is no specific use of that relative differential in terms of estimating the illustrative alternative. That information is presented to highlight that a growing disparity between payment updates in the Medicare program and other programs can cause pressure to the various systems. And so at some point, that there's possibility to have providers drop out of the program to the extent that Medicare is just not keeping up adequately. We have not seen many of those situations currently, but it is certainly a risk as that differential grows. And so if the differential is 2.5 times today, but we're still seeing robust enrollment in the Medicare program, then that in and of itself does not suggest that that's a problem. However, if that differential was to continue to grow, it very well might over time.
So,
but were you going to add something like?
Maybe against my better judgment. This is a really important issue. A few things I would say related to other MedPAC work. The first one is we have not seen access problems in the Medicare program dramatically related to these payment differentials, and we do focus a lot on the access of Medicare beneficiaries. So despite paying less than commercial, we have not seen Medicare beneficiaries have differentially worse access to providers in a range of ways, and that is a concern. We are concerned about the impact on a subset of providers, which is why MedPAC has a bunch of safety net recommendations, is a general point related to if some providers have too much Medicare, not too much, but have a large share of Medicare payment, what does that mean for their bottom line, and how might Medicare payment adjust for that? The other concern we would have is that high commercial payments could induce increases in expenses, and that, of course, can make Medicare margins change, which is another thing that we look at closely when we make our update recommendations, as you know.
Right. All right. Question for one or both of you. In urban areas, MA plan costs are substantially lower than the benchmarks. And it doesn't seem likely that the payment rates to providers in those areas are lower than the fee-for-service rates. So what is explaining that difference? Is it utilization management? Is that really explaining a lot of the spending differential? Is risk scores a factor? Is, what's going on there? I would posit is part of this post-acute care utilization trends. I don't know which one of you or both want to take this up.
I'll start unless Paul wants to start.
Go ahead, Mike.
So there's a lot of heterogeneity within urban and rural. So I just caution broad urban-rural statements. But let's just take what I believe this is getting at, which is take the 95% counties, which are the highest fee-for-service spending counties, and then the benchmarks is 5% below that. And the plans can do even better than that. And I think the answer is utilization. I think post-acute is an important part of that. So I think it's not prices, it is variation in use and the plan's ability to manage that use.
And one of so we're talking about the 25% highest spending counties in the country, and to say that the fee-for-service program in those counties to build in some degree of controls around that. And Mike's made this point earlier. It's actually easier to spend less off of a larger number than it is to spend less off of a smaller number. And so you're able to, plans have been traditionally more successful in these relatively high cost areas where they can do some utilization controls. Post-acute is the most obvious, but other areas as well. I think that's largely why, these MA plans have very high fee-for-service spending areas.
So I think we have time for one more question, and I'm going to combine a couple of questions. The trustees report and this whole presentation is really focused on the financial aspects of the program. But as Mike noted, also important are the quality and value aspects to the program. So I was just, Mike, if you can kind of talk about how to think about how Medicare Advantage program affects some of these other health outcomes and value and that kind of thing. And also, I don't know if Paul, this would be for you, but in this kind of value aspect, does CMS have any authority or desire to exclude kind of low performing hospitals in terms of health outcomes, readmissions, that kind of thing, from even being in the Medicare program and being able to accept Medicare patients?
There's a lot there. I'm going to just deal with the first part. And I'm going to say the second part to Paul about what CMS can do. Obviously, the payments to Medicare Advantage plans finance much more generous benefits. So the Medicare Advantage program is quite a good deal financially, I think, for a lot of beneficiaries. They don't have to buy a Part B supplemental plan. They get reasonably good coverage because a lot of the cost sharing is being bought down in a whole range of ways. They often get vision, dental, hearing, and a slew of other benefits. So in a pure, does the benefit package look better? You're getting much more, if you will, in the Medicare Advantage program than you would get in fee-for-service if you didn't buy a supplemental coverage plan. And if you bought a supplemental coverage plan, that's an added cost. So for the straight Medicaid, you're getting much more in Medicare Advantage. In terms of the quality of care, I think the evidence there is, broadly speaking, uncertain. I'm reasonably optimistic on the value, the quality of the care that Medicare Advantage plans are providing. I think they do a good job of outreach for chronic disease, for example, and a range of things like that. I know there's a growing concern about inclusion of certain hospitals and networks for, say, cancer care or other types of care. But I think the evidence would broadly suggest, although there's a wide range of uncertainty around this, would broadly support the notion that MA plans are comparable, maybe a tad better in some areas than traditional Medicare might be.
And on the question about what can CMS do, while I am quite comfortable speaking on behalf of CMS Office of the Actuary, I am far less comfortable speaking on behalf of CMS writ large. In all seriousness, though, there are many groups within CMS that are focused on developing the standards for participation in the program, monitoring those standards, adherence to those standards. And so that is certainly something that this agency takes extreme.
All right. Well, that's all the time we had for today. We did have some extra questions, but they were just for me, so I'm going to let them slide. Thank you both so much for participating today. And on behalf of Mike, Paul, and myself and the Academy, thank you for your participation in today's webinar. For additional information or questions, please contact Matthew Williams. The slides and recording of today's webinar will be available on demand to Academy members on your member profile within the next 3 days. To learn about and register for upcoming Academy webinars and educational programs, visit the Academy calendar events at actuary.org. And thank you and have a great day, everybody.